Good morning, ladies and gentlemen. I'm Mario Carminati, the Director of Pediatric and Adult Congenital Cardiology at Policlinico San Donato in Milan, Italy. And I'm very happy and grateful to be able to get part of this very outstanding meeting in India. So the topic I've been asked to talk about is the algorithm for percutaneous pulmonary valve implantation in patients with large right ventricular outflow tract. So the question is, are we choosing the correct timing for pulmonary valve replacement? The question is whether we are going to do that too early versus too late. We will try to get this answer to this important question. Well, the timing for pulmonary valve replacement according to right ventricular dilatation has been discussed in several papers published in the literature, talking about basically the volume of the end-diastolic volume of the right ventricle. And the magic numbers that were reported were in this paper 150 mils per square meter, or in other cases a bit more than that, 160, but the question were only related basically to the dilatation of the right ventricle. And these are the recommendations or guidelines for American European Association. And let's go more in detail about that. So going across the guidelines, the pulmonary valve replacement in asymptomatic patients are requested when the right ventricular end diastolic volume do not exceed the 160 mils per square meter, or the right ventricular systolic volume is 80 mils per square meter, or the right ventricular ejection fraction is depressed, meaning ejection fraction less than 45%, or when you have an associated obstruction in the RVOT with a gradient exceeding 50 millimeter of mercury, severe pulmonary regurgitation, the prolonged duration of the QRS, or other arrhythmias like sustained supraventricular arrhythmias or sustained ventricular arrhythmias. So all these criteria are the upper limits for intervene. So should we wait until reaching them? I would say no, and I will explain why. While in this paper reported some years ago, the optimal timing for pulmonary valve replacement should be considered before the end diastolic right ventricular volume exceed 163 mils per square meter, or systolic end volume exceeds 80 mils per square meter. However, in this paper, as you see, when you use the only end diastolic volume, only half of the patients can have full normalization of the volumes after pulmonary valve replacement. If you use the end systolic volume as well, is a better prognostic indicator of outcome. As you see in this slide reported by Bockman some years ago, if you have a right ventricular end systolic volume less than 80, 2/3 of the patient can normalize, as opposed to the others that cannot normalize if you intervene too late. And again, in this paper published by Terrian in 2000, is demonstrated that you can obtain clinical improvement and functional class, but exercise capacity is not improved after late pulmonary valve replacement. And another study from France, the French experience, demonstrated that the oxygen uptake is not modified simply by pulmonary valve replacement. And why this? The answer is that this problem may reflect the irreversible right or left ventricular lesions. So the authors encourage pulmonary valve replacement in patients showing any decrease in peak oxygen pass during their follow-up. And the right ventricular volume per se is not a predictor of outcome. As demonstrated in this study, the multi-center international tetralogy file registry called Indicator, published by Anne-Marie Valente, where the right ventricular volume is not a good predictor, as opposed to a combination of increased mass to volume ratio, low ejection fraction of the left ventricle, and the presence of atrial tachyarrhythmias. So you get the good outcome when you put together more than predictors and not only the right ventricular volume. There are other important factors influence the long-term outcome, represented by the scarring or fibrosis of right and left ventricle, as obtained by the information obtained by magnetic resonance, and as reported here in these two papers. So the pulmonary valve replacement options you have are obviously surgical, like using homograph Contegra or other conduit or bioprosthesis, and catheter interventional, considering balloon expandable valves that you know, the Melody and the Sapien, but there are a limitation in size for using balloon expandable valves. But there are self-expandable valves that are coming soon into the clinical practice that can expand the horizon of pulmonary valve replacement in the cath lab. And the choice, of course, may vary for institution. But again, just an example of a patient who were referred too late. That's a 30 years old tetralogy patient who had a repair at 4 years of age, asymptomatic for many years, but at 15 years of age, an ICD implant was necessary because of sustained ventricular tachycardia. And only at 36 years of age, this patient was admitted to our institution for cardiac failure. And as you see here, there's a huge heart on chest X-ray, and echocardiography showed as well a very large, very large right ventricle. So in this case, we implanted very successfully a Sapien 29 millimeters, as you see in this angiogram pre and post, with excellent hemodynamic immediate result, with abolishing completely the pulmonary regurgitation. And the patient on the midterm follow-up showed a clinical improvement, but the heart is far from returning to normal. As you see, you have a persistent heart enlargement. The right ventricle improved, certainly, but is still large, and we cannot obtain complete remodeling of the right ventricle if you intervene too late. So that's the concept that was explained and demonstrated in this paper reported recently, some years ago, showing that the time matters. As you see here, in two groups of patients who underwent pulmonary valve replacement, less than 10 years, less than 7 years of surgery, and more than 7 years. And it's clearly demonstrated that earlier interventions, meaning less than 7 years after last surgical RVOT correction, are associated with more pronounced reverse remodeling, leading to close or even normal right ventricular dimension and function, while it is not possible if you intervene too late. And again, is another important paper published more recently by Justin Treter and co-workers. And the conclusion is that defining and refining indication for transcatheter pulmonary valve replacement supports a more aggressive approach in those patients who meet inclusion for pulmonary valve replacement. meaning that pulmonary valve replacement can be considered as soon as an adult size bioprosthesis can be used. So that's a very aggressive indication. In conclusion, talking into the large RVOT that is not suitable for balloon expandable valves, but only with the new self-expandable valves that I report to you very, very briefly. This is an alter-adaptive pre-stent that you see used for implanting inside a self-expandable stent, the conventional Sapien 3 in the middle of the stent. And this had the FDA approval recently. And other devices like Harmony, produced by Medtronic, who recently had the FDA approval, and many patients had been treated in United States and Japan. The Venus PVR, which is a similar self-expandable valve stent produced in China, who's been used and recently got the CE approval, so can be used in Europe as well. And finally, the Pulsta valve that's produced in South Korea, and the CE mark trial finished for Europe almost 1 year ago, last December, and hopefully we will get the CE approval as well. But after you see an example of a Pulsta valve implantation, you see the CT scan, the simulation on the 3D reconstruction, and the angiography showing the valve, which is gradually expanded, as you see, getting the stent free from the delivery system. Then the delivery system is pulled back on from the pulmonary position. And in a second, you will see the valve stent very, very similar to the simulation pulmonary angiogram showing perfect competence of the valve. So the immediate result is great. And all around the world, starting from the pioneer experience from Gibeon Kim in South Korea, and then the commercial use in Korea or compressional use abroad in Taiwan, Argentina, Turkey, Vietnam, Thailand, and more recently, as I mentioned, the CE mark approval study in Europe, a total number of 340 patients were successfully treated with Pulsta valve implantation all over the world. So, just to get to the conclusion, what is the correct timing for pulmonary valve replacement? Well, obviously, it is too early if you have normal heart function with mild to moderate pulmonary regurgitation, mild right ventricular enlargement, normal biventricular function, no relevant arrhythmias, and normal exercise tolerance. These patients are doing well, so there is no need to put a valve in. But to the opposite end, it is too late when you have a reversible cardiac failure because of severe PR, very enlarged right ventricle, depressed biventricular function, sustained atrial or ventricular arrhythmias, and decreased exercise tolerance. So in the middle of these two extremes, we have to intervene with pulmonary valve replacement, but taking into account the procedure-related risk, the lifespan of the valve, obviously, the risk, the possible risk of endocarditis, the need of multiple valve replacement. So in conclusion, we have to get a correct balance that will guide to correct decision. So the strategy for follow-up of asymptomatic patient after tetralogy repair is consistent upon regular clinical consultation, ECG, Holter, exercise test, echocardiography, MRI, and you consider to intervene in case of deterioration. But the very, very important concept is that the longitudinal data are more important than absolute values. So the decision should be patient-tailored. So, in conclusion, as percutaneous pulmonary valve technology improve with better results and lower morbidity, the threshold for percutaneous way is likely to fall. Obviously, surgery still has a role for treating cases which are not suitable for percutaneous treatment or in cases where additional surgical procedures are needed. So I thank you very much for your attention.